Hello, my name's Kavian. I'm one of the clinical research fellows at Oxford University Hospital Trust. I gave you guys a lecture a few weeks back on an approach to the hypotensive patient, and the guys at OxPal asked me to do a bit of a midterm review, midterm quiz. I think it's usually helpful if you guys answer some questions and have some engagement and kind of think about some of the topics that you've been taught already. So I put together a really short quiz. There's only 8 cases there, and there's a couple of questions for each case. I think probably 15 minutes is lots of time. It doesn't have to be perfect answers. It's more just to get you guys thinking. So if I've put the link in the chat box already, if anyone has any trouble getting to it, I'll put it there again, and just click through. And it's all short. There's no multiple choice. I think it's I don't know. I always find it's better if you actually have to think of the answer. Yeah. So if you click on the link and you go through, and if we look to reconvene in another 15 minutes, and then we can go through the answers, and you guys can ask me any questions that you'd like. I've only covered the first 5 lectures, so I haven't done the last 2, the psychiatric emergencies lecture and the Burns lecture, Burns and major trauma lecture. But if you guys find this kind of approach useful, then please just feed back to OxPal and us, and we can make sure we do another session maybe just before Christmas, including the things that we haven't, the lectures that we haven't covered yet. So I'll see you guys shortly. The learning directives are to revise the approaches to a range of common presentations to the emergency room, be confident in your A to E approach, which has really been the bread and butter of what you've been being taught throughout all of the lectures. I looked through all of them and they've all covered the A to E approach, as well as the first lecture that you had from Natasha, which specifically went through the A to E approach. And then also being confident in managing key presentations within the hypotensive patient, acute chest pain, acute breathlessness, and the acute abdomen. So let's start with case 1. So looking through a lot of your answers, there's a range of answers that have come up on there. So there's myocardial ischemia, aortic dissection, MI, CVA, stroke, MI, cerebral thrombosis. Okay, so there's a variety of options that have come up. Really, what I was going for with this patient was that they have an aortic dissection. So I think only one person put that, which is interesting. So when I taught my session, I pretty much used an identical case. And the way I described it is that, anyone that gets sudden onset chest pain, particularly if it involves an arm as well, if there's been a syncopal episode, it can resolve. So sometimes if the dissection process has stopped, that means that essentially that the pain is going to stop and then it can restart again. So that doesn't mean it's not a dissection just because the pain's still not there. And equally, if there's any other involvement of kind of neurology, so if you get chest pain and CVA, kind of a cerebral vascular accident type picture, or if you get chest pain and some kind of limb ischemia type picture, then if you get 2 things coming together, chest pain and another thing, then you really need to think about whether aortic dissection is one of the things that is on your mind. It's a really important diagnosis. It's one that you cannot afford to miss. It has huge morbidity and mortality. And so really for this patient, it's super important that we're thinking that they're old, they're decompensating, tachycardic and hypotensive, and they have new neurology with sudden onset chest pain. It doesn't really fit with an MI type picture or an ischemic picture of the heart, really. They have lots of risk factors, including hypertension, being a smoker, having a previous MI. They're all risk factors for aortic dissection. So these are things that you need to think about. So aortic dissection was what I had in mind. The next steps for the patient, which was the next question, was to stabilize the patient. So I think a lot of you said that. this question is hard if you didn't get the first part of the question, but we'll go through it slowly, no problem, and just ask me any questions. So obviously, somebody that you think might have an aortic dissection, you need to stabilize the patient and you need to escalate early. So you need to find the underlying cause. We think aortic dissection in this case, get good access, fluid resuscitate them to try and bring their heart rate down and try and bring their blood pressure up. You'd think about doing an ECG, definitely that will help you. You know, if you are thinking about MI and things like that, then sure, you know, you might see that in aortic dissection. You tend to see some ST depression in the lateral leads and frequently. Do blood tests, most importantly do a group and save, or group and screen. It's called different things in different places, but it enables you to cross-match blood because this person is obviously decompensating because of a loss of blood. They're in hypovolemic shock, a hemorrhagic shock. So you need to replace that, which means you need to be able to cross-match units of blood quickly. Do a portable chest X-ray, which doesn't necessarily always show things, but might show other pathology. And then really the definitive investigation is to do a CT angiogram. So in terms of management, so the next question was, how would you manage this patient once the diagnosis was confirmed? The most important thing is to get cardiothoracics on the phone. They're the people that can definitively fix this person, even if they don't go to theatre necessarily. If they have a type B, they don't always go to theatre, but you need a cardiothoracic opinion. They will be leading on the care of this patient. They are the experts in this. You need to try and control their pain. You generally jump to using IV morphine or opiates generally, which will help with outcomes as well. And then you want to really control their blood pressure and their heart rate very closely. So you can use things like IV labetalol. This is kind of moving into intensive care territory, but you want to keep their heart rate low and keep their blood pressure relatively low to try and control and prevent the extension of the dissection, basically. And number 4, I've put ceiling of care as well. That's really important. So, you know, this gentleman is 80. Are they going to do well if they go to theatre? Is it appropriate for them to go to theatre? You need to have discussions with the family, with the patient, if they are able to, if they're conscious and able to speak to you about what the realities are of operating on a patient like this. It might be a palliative diagnosis. So that's case 1. It's a tricky one, but the reason I put it in there is, having worked in A&E for a little while now, for about a year and a half. You know, it's something that we have to think about regularly, and it gets missed and patients die. So it's not an uncommon diagnosis, but also it's a really important diagnosis not to miss, which is why I put it in here, and it's why I put it in my original presentation as well. So definitely take some time to go through my original slides, go through generally aortic dissection. Any questions at that point? If not, I'm going to move on, and you can just keep putting questions into the chat. So case 2, this is a 77-year-old. They were brought in by their partner. That's what BIB means, sorry. They've been struggling to mobilize over the last few days. They've got some right hip pain and fever, and they're pale and clammy. You can see on their observations that they are tachypneic, they're breathing really fast, and they're tachycardic and hypotensive. So this is looking like, again, a patient that's decompensating, that's in shock. You note that they've recently had a total hip replacement, that's THR, sorry, for a neck of femur fracture. That was a few months ago, but still within, you know, a relevant window for surgical site infection. So, you know, A is, what's the most likely diagnosis? Well, in this situation, it's a septic picture, really. If you go back there, they have a temperature of 38.5, so they're highly pyrexial. So with decompensation, hypotension, tachycardia, you need to think about sepsis as your top cause. And in this patient, there's no obvious focus, but certainly you want to think about whether it's a surgical site infection, or even worse, really, is there a deeper infection of the actual prosthesis that was put in? So they had a hip replacement. You know, there's increased risk for internal infection there following the surgery. Is that what's causing it? And you can get that up to a year after the actual surgery has happened. So 3 months is a reasonable time frame to be thinking about that. Second question was, what are the most important next steps? So obviously you want to stabilize the patient, go ahead with the sepsis 6, which again we went through last time, and hopefully you guys are familiar with, but you think about it in terms of 3 in, 3 out, and you want to do this as soon as possible, the absolute latest an hour after recognizing the risk. So, you know, most importantly, you want to do blood cultures, get a catheter in and do a lactate, but vitally you want to get intravenous fluids in and intravenous antibiotics in. Those are the 2 real most important things that is going to save this patient's life. Clarify the collateral, do some bedside tests. You might want to do a urine dip when you put the catheter in, do an ECG, looking for anything else that might be going on. They're known AF, you want to make sure they've not flipped into fast AF. Lab-wise, send bloods off if you want to culture the surgical site, definitely. And imaging-wise, you know, you want to think about doing an X-ray of the hip and the pelvis. Is there any evidence of deep infection? You might end up having to do a CT ultimately, but is there any evidence of osteomyelitis as well deeper in? There's an increased risk if you have a prosthetic fitting for kind of deep bone infections and things like that. Ultimately, this patient probably would go to theatre to have their hip replacement replaced, or they call it revised. Okay. Scoring system used to classify severity. Again, something that we covered in the last lecture is called SOFA, sequential or sepsis-related organ failure assessment. This is probably more a higher level, so kind of level 2, level 3 degree of care. So I'm talking about HDU, ITU. They tend to use this. They think about sepsis in terms of, and generally everything they think about in terms of organ dysfunction. So is it a 1 organ problem, a 2 organ problem, a 3 organ problem? And so this is a kind of a validated tool that's used to score and classify severity of sepsis. Okay, any questions after case 2? So case 2 wise, septic, pulmonary embolus, septic. So great, lots of people are along the right lines. You want to stabilize a patient, give important things, image the hip, absolutely, fluids and antibiotics, all correct things. And SOFA scores is brilliant. This is a hard one, so sorry, but yeah, lots of you have got it, so that's really great. Sorry that I'm going fast, but hopefully it says, you know, you guys know a lot of what this is already, so it's kind of retouching. So case 3, a 62-year-old female, central chest discomfort. It started whilst they were walking up the hill to the shop, so there's an exertional element. They're quite stable in terms of their observations, but they have a couple of cardiovascular risk factors. They have a 30-pack-year history of smoking, so quite heavy smoker, type 2 diabetes. And I also included an ECG to make things slightly easier. So lots of people, as I can see in the answer to question 1, have written anterior or anterolateral infarct, which is absolutely spot on. So if you look here, you can see ST elevation in V1, 2, 3 quite clearly. And there's also some in 1 and also down in V5, a bit more subtle, probably V5, V6-ish, V4 possibly. So, and you can see vitally reciprocal ST depression in the inferior lead, so 2, 3 and AVF you can see here, which kind of is really helpful in telling us that, you know, this is likely a true ST elevation. So, next question was, what are the most important immediate next steps, investigation-wise, that you want to do? So if we look at what we said, yes, kind of the right things. This is probably my fault for not wording it very clearly, but you're saying the right things, absolutely. So essentially, the first thing I would do is if this patient has a ischemic sounding history together with very clear territorial changes for ST elevation, I would alert the cardiologist as soon as possible and activate the cath lab, saying we have a potential patient that might need primary percutaneous coronary intervention, so a stent put in, or some kind of angiographic intervention. So that's the first thing I would do. Move them to a monitored bed in the resuscitation room, so the highest kind of alert room where there's a high ratio of nurses to patients. So a 1-to-1, one nurse to one patient, for example, where they can really closely monitor the patient. Do serial ECGs just to make sure that, check if the changes are dynamic or not. Is there a kind of serial change in the ECGs that you do every 15 minutes or every half an hour? And also you want to compare against old ECGs to make sure that the changes are new. And then absolutely, as pretty much all of you said, you want to do cardiac enzymes and other blood tests as well, including clotting. If they're going to go for PCI and they want kind of femoral or radial access to go in, you want to know what their clotting is. This you can read kind of more in your own time, but you know the concept. So the criteria for MI essentially is a combination of a rise in troponin, or some places use creatine kinase MB, with at least one of the following, which is ischemic symptoms, which we have here. Development of pathological Q waves, which tends to show old MIs. We probably don't have time to go into it, and I haven't put it into my presentation, but if you guys are unsure, you can email me about Q waves. ECG change is indicative of ischemia. So we've seen here ST elevation and reciprocal ST depression, and also if they've had some kind of coronary angiography recently that showed ischemic type changes, that there were big blockages, that also counts. In terms of criteria specifically for a STEMI, you want to look for a new or increased persistent ST segment elevation in at least 2 contiguous. That means 2 leads that are next to each other. So that would be, V1 and V2, or V2 and V3, or whatever. And you want more than, this is assuming a normal calibration, more than 2.5 small squares high in men less than 40 years old, more than 2 small squares high in men more than 40, and more than 1.5 small squares in women in V1 and V2 and V3, sorry, or it can, simply 1 square high in the other leads is enough. So that's just something that you kind of have to read and have to know, but it can be very subtle. If it's just 1 small square that you need, that's something that unless you look for carefully, you might miss, and that can be catastrophic. And another thing to say is that this patient, it was a female patient with a background of diabetes. They had some chest discomfort and not much else, to be honest. So actually in those patients, in diabetic patients, in females, and also in elderly patients, you can often get atypical presentations of MIs and STEMIs actually. So they don't necessarily have crushing kind of central or left-sided chest pain radiating to the jaw and the arm. You can get abnormal presentations that are slightly more subtle. So always keep that in your mind as well. These are the different territories. Again, something that's worthwhile you guys learning. It makes sense if you think about where we put the leads on when we do an ECG, where V1, 2, 3, and 4 go. They go across the front of the chest. So that's going to be the anterior aspect of the anterior septal aspect of the heart, for example. Similarly, 1, AVL, V5, V6 are going to cover kind of the lateral side. But you kind of need to learn this, unfortunately. It makes sense logically, but it's really important for you to commit to memory. The next question was, what's going to be the immediate management for the patient? Here, right thing. So you put heparin, beta blockers, aspirin, so dual antiplatelets, absolutely. Morphine, oxygen, nitrate, so MONA, yeah. PCI after initial treatment, absolutely. PCI, oxygen, catheterization, I'm assuming you mean PCI, MONA, PCA. Okay, great. So again, all on the correct lines. You want to control oxygen saturations. Over oxygenating the patient has relatively recently, in the last few years, been shown to be bad and actually can drive or exacerbate ischemic changes. You want to control the pain, so use morphine, give them antiemetic because she was feeling sick, and then dual antiplatelet therapy as per your local policy. So here we tend to use aspirin. We used to use clopidogrel. Now we tend to use ticagrelor generally. That's the kind of nice guidance. GTN can be helpful again in relieving the load and relieving pain as well. And then you need to think about thrombolysis if PCI can't be offered. This is a nice kind of schema. This is from the BMJ. You can't probably necessarily see it very clearly on the small screen, but you'll have it in the slides. So I'd urge you to go and have a look at it. So on to case 4. So let's go through this case, and then maybe we'll kind of slow and we can take a few questions before we go on to the next 4 cases. So I'll go through this case quickly again. Hopefully relatively straightforward, this one. So sudden onset sharp chest pain, worse on a deep breath in. So it's pleuritic with associated shortness of breath. They have a background of having had a previous DVT, and also on this occasion, you know, they're complaining of a swollen right calf that's tender, and they've had recent major surgery after I put an RTA. That's a road traffic accident. It's not super important for the question, but that means that, you know, they had major trauma to their pelvis and they had recent surgery a couple of months ago. They are potentially starting to decompensate. They're slightly hypotensive and tachycardic, and they're certainly desaturating. 88% on air. There's no reason why they should be that low saturation wise. So the first question was, what's your top differential? And I'm hoping most people put a PE. I'm sure you guys did. And yeah, P, DVT and P, yeah, very reasonable. Scoring system that you use, again, there are a few, you're absolutely right, that you use, certainly here, and as far as I'm aware, in most places, the kind of Wells score or the simplified Wells score is what they tend to use because of the ease of application, really. And this patient, in that context, oh, sorry, so let me go back. What's your top differential? P, I just wanted to put a quick note in about the difference between, so in this context, actually, this would count as a massive or high risk PE. I know that Zia, the person that gave you the lecture, originally covered this, which is why I put this in here, and I think it's important, which essentially means a PE which is driving decompensation, so sustained hypotension, pulselessness, or a profound bradycardia. So essentially they are unstable as a result of their massive PE, or PE. That means that the PE is massive. Submassive or intermediate risk essentially means without systemic hypotension, but you have some right ventricular dysfunction, and we'll come to that in a little bit. But obviously, you know, where the pulmonary vasculature is involved, there's going to be back pressure on the right side of the heart, the right ventricle, and the right side of the heart generally. So that represents a submassive PE, and also if there's any signs of myocardial necrosis as represented by a rise in troponin, then you might also consider it to be without it being primary MI, then you might consider it a submassive PE as well. So scoring system that we use, we discussed, it's the Wells score, and we've gone through. So this person would score 3 for signs or symptoms of DVT, alternative diagnosis less likely than pulmonary embolus, i.e. what that one means is that the most likely diagnosis you think is a pulmonary embolism. So they already score 6. They are tachycardic and they've had immobilization, so that's another 3, so that's 9. And they've had a previous venous thromboembolism, the previous DVT, so they would score 10.5. You only need a cutoff of 4 to qualify you as high risk. Okay, so this person is immensely high risk for having a PE or some kind of VTE. So bonus question. So this is when this question, hopefully the first two questions were relatively straightforward in this particular case, PE and Wells score. This question is a bit trickier. So what bedside tests could be done to help aid diagnosis? So in terms of what you guys wrote, we have a chest x-ray, which you're absolutely right, yeah, an ECG. This is a great answer. Low limb ultrasound, yeah, absolutely. So if you're looking for the DVT, D-dimer, CT angiogram, yeah, so a clinical sign for DVT, potentially ABG, D-dimer, VQ scan, ECG, calf pain, D-dimer. So the answer actually that I was looking for is none of those things. In the context of someone that is hemodynamically unstable, who's had a massive PE, so you know, all of your suggestions were very reasonable, but in the context of someone that's hemodynamically unstable, that's decompensated, who's had, we think, a massive PE, you would do a bedside echocardiogram. Because they're too unstable to go to CT. You know, if they arrest in the CT scanner, that would be a disaster. So only in this particular context, with a massive PE and hemodynamic instability, you would go ahead and get someone who is able to do a bedside echocardiogram. And you're mainly looking for any signs of right ventricular dysfunction. So that might be actually, you see clots or mobile clots in the right side of the heart. On the echo, you see dilation or hypokinetic, which basically means reduced movements of the right side of the heart. Or you might see evidence of pulmonary hypertension. You might see issues in the IVC. These are all things that represent right ventricular dysfunction. So you don't need to know the ins and outs of this, but it's worthwhile you knowing. And I think it's, you know, it's probably higher level knowledge, merit or distinction level knowledge to say that in the context of an unstable patient, you'd use a bedside echocardiogram to figure out whether you think the patient has a PE and you want to push forward. Next steps for the patient. What would you do for the patient next? There was a question. Yes, yeah, so escalate and stabilize the patient, and you'd consider thrombolysis. So particularly in a big PE like the one that you have here, that's something that you really think about. It's a senior decision to be made, so a senior registrar on the shop floor or one of the consultants. And actually, if the patient is peri-arrest and you think that, you know, say you've got a collateral history that the patient had sudden onset shortness of breath, that's pruritic and sharp chest pain, and then now they look peri-arrest and they have a super high Wells score, and you think that actually they're going to go into cardiac arrest, it's very reasonable to actually just thrombolyze them without doing any kind of investigation. So even an echo or a CTPA. In a non-massive PE, you'd go ahead and give treatment dose low molecular weight heparin. So the 1 and 2 I'm talking about in this case for this patient who we said has a massive PE. In a non-massive PE, you'd give them low molecular weight heparin, a treatment dose, or unfractionated heparin. And then you'd switch over to anticoagulation once the venous thromboembolism was reliably confirmed, you know, for example, on CTPA. This is a schema from Mohammed, Dr. Abdul Rahim's presentation, which is helpful and you guys can have a look at and you probably know already. Fine, so we're halfway. How are we doing? Any questions at all from what I've covered so far? So the cases, I've tried to pick not too niche cases, but I've asked some slightly more tricky questions. Fine, so I'm going to go ahead. I'm going to take the silence as you're happy for me to go ahead. So case 5, a 35-year-old female out for an early morning run, sudden onset shortness of breath. They've been a bit sniffly, kind of had a bit of a sore throat, a bit of a runny nose recently. So maybe they have a kind of a flu type picture. Her partner notes that she had an audible wheeze initially until about 15 minutes ago, but this appears quieter. However, notes that the patient is in more distress and perhaps disorientated and confused now. has a background, known background of asthma, is atopic, has a hay fever, and takes salbutamol as her reliever and beclomethasone as her preventer inhalers. At triage, she's very hypoxic for someone that's otherwise fit and well, 86% on air. She's tachycardic, hypotensive, and she's tachypneic. She's breathing really fast, and she's slightly pyrexial as well. So if we look at what you guys, so how severe is this exacerbation of asthma was the first question. We had moderate, severe, acute exacerbation of asthma. You're right, silent acute exacerbation of asthma, spot on, mild. You don't understand the question or the point of the question. Sorry, that was my fault if it wasn't clear. I'll explain to you the point of the question in just a second, but you would be right to say that this is really it's a life-threatening severity or hyperacute, very, very severe presentation. In this, the Global Initiative for Asthma kind of guidelines that is one of the main guidelines that we use globally. If you look right at the top and you follow the flow chart, any of the following present: drowsiness and confusion, so it's a kind of disorientation would count as that, and silent chest. So she actually was audibly wheezy initially, and then her partner said that's got much quieter and she can't really hear it anymore. All of those things suggest that this is pre-terminal, that the person's starting to fail, that they're starting to go into respiratory failure, potentially converting from type 1 respiratory failure into type 2 respiratory failure. We'll go into that in a second. And so this is really bad. This is really serious. The point of the question is that for the person that put this right at the bottom, essentially when someone comes into ED, into the A&E department, and they have an acute exacerbation of asthma, what we treat them with, as you can see from the flowchart, differs based on how severe the classification of the exacerbation is. So it's really important for us to figure out how severe the exacerbation is. There's other guidelines that exist as well that use kind of peak expiratory flow, which is also really, really important, but I put this in because this is clinically really easy to understand and something that we use every day as well. So the next question was, what would be your first steps in this patient? So if we go to the top and look through what we wrote: oxygen, salbutamol, steroid, magnesium, adrenaline, absolutely. Inhaled corticosteroid and antibiotic, brilliant. Saba-laba, adrenaline, intubation may be needed, fantastic, whoever wrote that. Inhaled corticosteroids, long-acting agonists, yep. Ventolin, Diacort, salbutamol, IV epinephrine, yes, potentially. Saba, antibiotic, yep. So all good suggestions for sure. So ATE assessment and stabilize the patient, again, obvious, but it's worth you guys saying. If you're in an OSCE or practical exam, you have to say that first. In this situation, you want to give nebulized, short-acting beta agonists, so salbutamol, and also anticholinergics, so things like ipratropium bromide or Atrovent is a trade name. And you can actually drive them either with air or with oxygen. Given that this patient is hypoxic, you want to drive those nebulizers with oxygen. You want to give early corticosteroids. If they're able to tolerate oral, that's great, because the evidence shows that there's no difference in outcome between oral steroids and intravenous steroids that are given. And you tend to give on discharge 5-day course of once daily 50 milligrams of prednisolone. That's enough. These are the really important things which you guys mentioned as well. You want to escalate to the intensive care team early, and you want to prepare the airway trolley, which is essentially where you have all the different things, the kit that you need to intubate the patient, because she looks like she is going to potentially lose her airway. She's working really hard. Her chest is going silent. She's starting to become confused, potentially means that she's not mentating well. So she's not getting kind of oxygen to the brain, etc., etc. And she may need intubation. So you want to involve the intensive care team and the anaesthetic team early. And then also magnesium infusion you want to think about. This patient is technically pyrexial, hypotensive, tachycardic, and maybe had a bit of a flu or some kind of sore throat or chest infection. So I would treat them as if they have sepsis and go ahead with a sepsis 6 as well. Bedside wise, yes, the peak expiratory flow you want to do, not in this patient who's kind of peri-arrest almost, but once they start to improve, you want to do a peak expiratory flow and then use their the percentage. So the percentage that you use is actual peak expiratory flow over their ideal peak expiratory flow as a percentage, and then you want to see how much they're improving or not. And an ABG or indeed a VBG, ABG is probably better in a respiratory patient here, but often a VBG is pretty good as well if you just want to look at the carbon dioxide really. And a portable chest X-ray is again very, very helpful. Is there some kind of underlying pneumonia that's going on that's driving this? And laboratory wise, standard things that you'd send off. So the last question was, why might a PCO2 of 5.5, which falls within the normal range, be concerning to you in this patient? So normal elevated, it's of concern. Severity, may need intubation, absolutely. Status asthmaticus, absolutely. Bang on. Impending respiratory failure, yeah, respiratory failure. Brilliant. So this is, I thought this was quite a hard question, but obviously not. You guys are absolutely spot on. It basically means that the patient, they should have a low PCO2 because they are working very hard. They're tachypneic, they're hyperventilating, so they should be blowing off lots of CO2. But obviously it's not very effective because their CO2 is normal. So in someone that's healthy, who is tachypneic, you would expect a PCO2 to be low, very low. Whereas here it's normal, suggesting that there is impending respiratory failure, and you might want to think about wanting to intubate and ventilate this patient. So brilliant. Yeah, I've just written what I just said. Cool. Case 6. So only 3 more cases left. I know it's a bit of a long one, but hopefully it's a helpful session to go through these questions. Case 6, a 30-year-old female stabbed by their partner in the left side of the chest. It's another kind of a domestic violence case, and they're visibly short of breath. No relevant past medical history or drug history. They're tachypneic, they're breathing very fast, and they're starting to become hypoxic. They're tachycardic and they're hypotensive. Temperature's okay. What are the potential complications from this incident? So if someone's been stabbed by a partner in the left side of their chest with a knife, what do you think might happen? So we'll go and see what you guys said. Potential pathologies: pneumothorax, hemothorax, injury to organs, absolutely, yeah. Lung collapse, injury to lungs, heart, thoracic organs, upper part of stomach, yep, spot on. Tamponade, left subclavian injury, yeah, can be, absolutely. So to the great vessels, effusion and tamponade, pneumothorax, spot on. So potential complications. It's good if useful always to try and classify. So break it down into by system. So cardiac, you can get a pericardial effusion. Actually, it's quite unusual, and you wouldn't expect to see it for a few days at least after someone's been stabbed. But yeah, it's worth including. And certainly cardiac tamponade is a really, really important complication potentially. Respiratory complications: pneumothorax, hemothorax, human pneumothorax, where you have both, and also you can get diaphragmatic injuries. And GI-wise, you can get kind of bowel injuries, and you're absolutely right, you can get injuries to the big vessels as well, which can cause you to internally bleed out. Next question was, on examination, the patient's trachea was deviated to the contralateral side, so away from the side of the injury to the right side. What's the diagnosis and what are you going to do next? So we've said tension pneumothorax, needle decompression, absolutely. Human pneumothorax, yeah. Yeah, tension. Perfect, great. So tension pneumothorax, I'm going to go ahead and assume, just for the purposes of time, hopefully you guys are happy with what a tension pneumothorax is. This is quite a nice animation video because I actually conceptually, initially when I learned about tension pneumothoraces, couldn't really picture it. So that was really helpful for me. So you guys, when you get the slides, can click and watch that. This is obviously a chest X-ray. Can anyone tell me what has happened here for bonus points apart from the tension pneumothorax? Can you see anything? It's very hard to see on not a big proper screen, but actually there's a couple of rib fractures here. So this isn't actually the X-ray from the patient that I'm talking about, but just to say that, yeah, absolutely, Said was spot on. So that you need to look for not just the obvious thing, but actually whether there's other things going on as well. It's relevant that this person has had rib fractures, because they might be the cause ultimately. I mean, this particular X-ray, not our case, might be the cause of, you know, blunt trauma leading to rib fractures. They might have a flail chest that might have caused the pneumothorax, tension pneumothorax. Brilliant. So first next steps was the next question. A2E assessment and stabilize the patient, escalate to seniors. Really, this person has a very high risk of cardiac arrest. There's no joke, tension pneumothorax. If you think about your advanced life support or your basic life support, it's one of the reversible causes of cardiac arrest. So you don't want to let it get there. So you want to take them to a emergency room resuscitation bed. Oxygen can be really helpful. And sorry, I didn't finish the sentence there. Essentially, I mentioned why oxygen can reduce. It's to do with demand obviously in the blood, meaning that it can kind of slow your breathing down and reduce the load, hopefully reducing the chance of the tension pneumothorax getting bigger. The main thing you want to do is a needle decompression, which we'll talk about in the next slide, and most of you said. And the other thing that you might do, particularly in the context of a traumatic patient, so this person has had a traumatic pneumothorax in that they had an external object that was, you know, caused them to have the pneumothorax, tension pneumothorax, is you might do an open thoracostomy, which is where either if there's a hole already, you might use a clean gloved finger to blunt dissect in and create a tract so that the air from the tension pneumothorax can be released, or if that's that tract from a stab wound or blunt trauma has started to close up for whatever reason, you might use a scalpel to open it back up again and use your finger to create the tract again. Small print, it's worth reading up about it. It's very interesting if you have some kind of interest in pre-hospital medicine and big trauma. You want to do imaging, so portable X-ray is really, really helpful once you've done the urgent needle decompression. So imaging should never, ever, if you clinically think there's a tension pneumothorax, you need to go ahead and do a needle decompression with whatever supervision that you need. But you shouldn't let imaging delay doing an urgent needle decompression, because there's a risk of cardiac arrest ultimately. And then definitively a chest drain. You also want to do serial X-rays once you've done interventions to see how the tension pneumothorax is resolving, and then input from a respiratory physician. So the last question was, what are the options if the needle decompression, which is the first line, hasn't worked? Well, you would go on to an open thoracostomy if you can, and if that also doesn't work and the needle decompression doesn't work, then you would have to go straight to a chest drain, really. And this is just a picture showing the different sites. So the two main sites where you can, it's accepted by the Resuscitation Council that you can insert kind of a needle decompression. It can be in the second intercostal space in the midclavicular line, so here, or it can be in the fifth intercostal space or the fourth intercostal space. Some say even the third intercostal space, just anterior to the mid-axillary line, so just along the side here. And you're basically, by putting a needle in to decompress, you're aiming to convert a tension pneumothorax into a simple pneumothorax. So this won't work for a simple pneumothorax. It's not the right management, but you're trying to convert a tension pneumothorax into a simple one to restore the normal perfusion and oxygenation. So you're trying to pull that mediastinum back into the middle, pull the trachea back into the middle, reinflate the lung and reinflate or kind of enable all the big vessels, particularly your venous system, which has low pressure that might be compressed by all the things that are going on in your thoracic cavity as a result of tension pneumothorax. But by resolving that, you're enabling those to open back up again and enabling flow around the venous system again. Case 7, nearly there, last couple of cases. Hopefully relatively straightforward. 20-year-old female, 2-day history of worsening abdominal pain. Started in the umbilical region, moved down to the right iliac fossa. They've had some nausea and vomiting and reduced appetite. No other past medical history or drug allergies. And they're relatively stable, slightly tachycardic and normotensive, but they're ever so slightly pyrexial. What's the immediate next steps to aid diagnosis by the bedside? So what's literally the next first thing that you're going to do? So physical examination, absolutely. Physical exam, yeah, you want to think about ultrasound, urine analysis, yeah, physical exam, great, ultrasound, and various signs and ultrasound. So, yeah, so all absolutely spot on, actually. I was looking for the simple thing, which is just an examination. So you want to do an examination. Are they peritonitic? Is there any, so I know there's kind of McBurney's sign or McBurney's point, which is meant to be the point of greatest tenderness, or Rosving's sign when you press in the left iliac fossa, leading to tenderness in the right iliac fossa, psoas sign where you flex the hip and you flex the knee and you internally rotate, and whether that can cause irritation of kind of a retrocecal appendix. They're all potential signs, but really the most useful in terms of evidence-wise is rebound tenderness and percussion tenderness, both of which test for kind of localized peritonitis. So examination is the single most useful thing you can do. It's a clinical diagnosis of appendicitis. So whatever any surgeon tries to say in terms of rejecting your referral, when you're working, if you think this person has appendicitis, there's no blood test that you should have to wait for. It should be, you go ahead with the examination. So then you want to do a pregnancy test. This is really, really important. One of your top differentials is an ectopic pregnancy, okay? It's mega dangerous if you miss this. This is a young, woman of childbearing age who could have an ectopic pregnancy. So it's pretty vital that you don't miss this and that you do a pregnancy test. Urinalysis, again, is an easy thing to do. UTIs can easily be mixed up with surgical presentations if they have dysuria. I'm really sorry, there's someone at the door, which I'm just going to answer. Where was I? Okay, yeah, next steps. So you've done an examination. Pregnancy test is really important. This is a young girl, childbearing age. Urinalysis can be helpful as well. And then you want to give analgesia early and an antiemetic. This person's vomiting, they feel really nauseous, they feel rubbish. You have to think about it in terms of optimizing how the patient feels and trying to make them feel better. So, it doesn't matter. You don't, sometimes surgeons are like, oh, but you don't want to obscure the sign when I come and examine the patient. No, that's incorrect. If the patient is in pain, you need to relieve the pain. If they feel nauseous and sick, you need to relieve that. So that's the most important thing for you as a as the emergency room doctor to do. There are a couple of other things that you want to think about. I haven't gone into it in this particular instance, but you want to think about ovarian cyst accidents. So this is a young girl, have they had an ovarian cyst torsion? Has the ovarian cyst bled into itself or bled out, or has it ruptured? So those are the three things: torsion, hemorrhage, and rupture of an ovarian cyst. Is stuff that you need to think about. But the fact that it seems very classical that you have centralized abdominal tenderness, umbilical, which is then migrated into the right iliac fossa, is pretty classical. So I focused on appendicitis in this case, but those are the ovarian cyst accidents are things you need to think about, and doing an ultrasound scan would help you massively in excluding whether that has happened or not. So you might want to speak to the gynae team, the gynecology team on call as well if you're unsure. Why does the pain move? So I think the consultant surgeon that gave you the lecture on acute abdomen spoke about this. Again, it's worthwhile. It kind of goes back to the anatomy. So most likely diagnosis was appendicitis, absolutely. Visceral pain, and then to serosal pain, yes, or somatic pain, I guess we call it. Yeah, visceral pain becomes parietal, absolutely, because of peritoneal irritation. Yeah, so you're absolutely spot on. You guys know this already, and it's small and it's clinically doesn't really make that much of a difference, but surgeons like you to know this kind of stuff that links to anatomy. So periumbilical pain initially is because of the irritation of the visceral peritoneum, which is innervated by the splanchnic nerves, which innervate the whole midgut. And they aren't sensitive to pain. They don't have pain-related fibers, and so it's referred to the T8 to 10 dermatomes, which is around the umbilical region. And then as soon as you get increased inflammation, that might grow and irritate the parietal peritoneum. That is innervated by somatic nerves, and so you do get kind of localized pain there. Just a note to say that 50% of appendicitis kind of appendicitis related issues don't present in a classical way, because there's lots of different positions that the appendix anatomically can be in, which is a variant of normal. Okay, so you see here retrocecal, subcecal, pelvic, pre-ileal, post-ileal. I'm not going to spend too much time on this, but yeah, retrocecal or retrocolic, which is 20% of cases. You don't necessarily get the muscular rigidity and the tenderness to deep palpation because actually the appendix is behind the cecum, and the cecum is obviously one of the biggest parts of the bowel, so it protects that. But you might get the psoas muscle irritated, so your psoas sign might be positive. Similarly, etc., etc. You can have a little read through that. I'm just wary of the limited time that we have. So management is really the next question. How would you proceed? So if we quickly look at what you guys wrote: appendicectomy, surgery or antibiotics and IV fluids. Surgery, admit and operate. Yes, 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 surgery. So here, surgery, you're absolutely spot on, but I kind of wanted you guys to start thinking about the practical things that you should be doing, which is as important really, or more important, sure, of course, we will proceed to surgery probably, but you want to do blood tests and you want to make sure you take a group and save. They, generally for them to be happy to take a semi-urgent case, which is what this would be, to theatre, they would want a group and save on the patient. And you also want to check the lactate. Again, it's a way of us kind of tracking the severity of what's going on, any kind of intra-abdominal ischemia leading to increased lactate. You want to refer to the surgical team. Again, it's a practical thing. Obviously, you would do it, but it's worthwhile in an OSCE or in a practical exam. You need to say these things out loud. Make the patient nil by mouth. Again, it's a really great thing that will make you stand out because it's very practical. Yes, you want them to go to theatre, but what are the things that you need to do to make them ready for theatre? Make them nil by mouth. Start intravenous antibiotics, as somebody said. And ultimately, like you said, this person will go for surgical intervention. There's a role for ultrasound scanning, which I know a lot of you mentioned as a bedside thing that you could do. So you're absolutely spot on. You're totally correct that ultrasounds can be helpful in diagnosing appendicitis. There's a very recent New England Journal of Medicine paper that literally came out last week that essentially has looked at relatively straightforward appendicitis presentations, and it's a randomized controlled trial, randomizing them to surgery and to intravenous antibiotics, and it's showed that antibiotics are non-inferior, so they are no worse than taking a patient to theatre. Obviously, there are certain caveats, and it's a bit more complicated than that, but it's very interesting that we might actually start moving away from taking everybody to theatre, because there's obviously morbidity kind of associated with unnecessarily taking people to be operated on. Fine. Last case. Well done, everyone, for sticking through with it. And thanks very much for your patience. Case 8. So a 66-year-old male, a 5-day history of worsening abdominal pain is pretty bad. It's 9 out of 10. Localizes to the left iliac fossa initially, but today it's spread to the whole abdomen. Couple of days of nausea, vomiting, can't keep anything down. B&O, sorry, I'm sorry if this wasn't clear. It's bowels not open, which is quite an important part of the question. So apologies from my end. bowel's not open for 48 hours, so 2 whole days, which is abnormal for the patient. A few days prior to that, they've also had some change in bowel habits, so they've had some blood in their stool mixed in, and on the way here in the ambulance, every small bump in the road when the ambulance was driving to the hospital was incredibly painful. Has a background of diverticulosis, no drug allergies. They are working really hard, so they're breathing really, really fast, 37 breaths per minute, which is huge, but they're saturating well, really tachycardic and pretty hypotensive, 90 systolic, marginally pyrexial, 37.6. So what's the next immediate steps for this patient? What are you thinking? So you guys have written fluids nil by mouth, absolutely. Nasogastric tube, urinary catheter, antibiotics, nil by mouth. ABC, resuscitate, absolutely. Nil by mouth. Operating theatre for laparotomy, fluid antibiotics, colonoscopy potentially. Yeah, that maybe has a role. ABC, you're completely spot on. Good. So you all of you guys are absolutely right. This patient, appears to have obstructed and they've potentially perforated. This can happen for lots of different reasons that we'll go into, but in this case, obviously the colon that's proximal to the cause of the mechanical obstruction, whatever this is, usually dilates, and because of the increased colonic pressure, so this is just the pathophysiology, colonic pressure, essentially the mesenteric blood flow, the mesentery obviously supplies the blood to the colon and the colon wall. That mesenteric blood flow is reduced because of the intracolonic pressure being increased. And as a result, there's kind of mucosal edema, and eventually the arterial blood supply becomes worse and worse. There's kind of progressive ulcerations, there's ulcers in the mucosa that develop, and slowly but surely there's kind of full thickness necrosis. So initially there's ulceration, and then the necrosis goes deeper and deeper until it's the whole thickness of the wall, and eventually you get the perforation. So that's kind of why you perforate. Immediate next steps are going to be stabilize the patient. It's really important that you do a per rectal examination or a digital rectal examination for you to be able to find out the level of the obstruction. If you do a digital rectal examination and you find that there's no stool in the rectum, it's empty, then you know that the blockage is going to be kind of proximal to the level of the rectum. If you know that there's some soft stool, then you probably know that it's a partial obstruction. And if there's hard impacted stool, then you know that probably actually it's a case of kind of extreme constipation that's potentially caused them to back up, to be obstructed and to rupture, to have a perforation. You want to again give them analgesia and antiemetic. They're going to feel absolutely pants. They're going to feel rubbish. It's a really horrible thing to go through. Refer to the surgical team urgently and do imaging. So it depends on how bad they are. This patient is pretty unstable, so they might not tolerate an erect chest x-ray and an abdominal x-ray. Clinically, it's pretty barn door for an obstruction type picture. So they might actually go ahead and do a CT abdo, having resuscitated the patient appropriately. They're going to need a contrast CT abdo-pelvis before they take them to theatre usually, to be able to plan appropriately where the blockage is and what the approach is going to be. Blood tests, again, lactate and group and save. Make the patient kneel by mouth, like you said, and then drip and suck. Again, all things you said already. So IV fluids, site an NG tube so that you can decompress the stomach and hopefully reduce the amount of volume going out through the perforation, or stop it becoming bigger. Intravenous antibiotics. This is a nice little slide that differentiates between small and large bowel obstruction. I think you probably know most of it already, hopefully, and if not, again, I'm kind of weary of our time restraints. It's a really useful and beautiful table from the reference I've put in the corner, so you can kind of read that in your own time, but that there's kind of subtle differences between a small and a large bowel obstruction. So the second question was, what are the most common causes of bowel obstruction, small bowel obstruction and large bowel obstruction? This is a classic question that the surgical team and surgical people love to ask. So adhesions, absolutely, and hernia for virgin abdomens. Yeah, you're absolutely right. Small bowel is adhesions and hernia. Large bowel is colon cancer, spot on. Previous surgery, strangulated hernia. Yeah, interception, large tumor. Brilliant, great, super. So cause of bowel obstruction, the most common cause of the small bowel obstruction is adhesions from previous surgery, and also hernias that become kind of obstructed or incarcerated, that become, yeah, kind of blocked essentially, so incarcerated. Of a large bowel obstruction, by far and away the most common cause is a colorectal malignancy. So in this case, probably this poor person has likely a colorectal malignancy, kind of in terms of by chance, 90% is colorectal malignancy. They've had a change in bowel habit. If you dug deeper, maybe they've had some constitutional symptoms. Maybe they've had some loss of appetite, some weight loss, things like that. It can also be caused by benign strictures or a volvulus. I'd again stress that it's really helpful to try and classify where possible, particularly in finals. It's really helpful. You score much, much more highly if you're able to say one cause for each subcategory. So even if you only gave 3 causes of bowel obstruction, but you said, bowel obstruction can be caused by intraluminal etiologies, such as fecal impaction, mural etiologies, such as some kind of malignancy, or extramural etiologies such as adhesions, that looks significantly better than being able to list 10 different causes of bowel obstruction. So you really want to classify. So have in your mind, I'm sure you guys have come across surgical sieves and things like that, inflammation, infection, inflammation, malignancy, etc., or vitamin D. Some people use. There's lots of different ones. So I'd learn one of them and use that approach. It's really helpful, particularly for exams. But yeah, so intraluminal basically means just inside the actual lumen. Mural means as part of the wall of the colon or the small intestine itself. And extramural is a compression, basically something from the outside compressing in. What are the risk factors for diverticular disease? I just wanted to pick this out because it was covered in your acute abdomen lecture, and it might be something that you get asked in your written questions. Written exams, sorry, but risk factors for diverticular disease, they again classify if you can. So modifiable, low fiber diet, smoking, obesity. Non-modifiable, there's a significant genetic proportion component to your risk of diverticular disease. That's it. So that's a whistle-stop tour. Thank you so much for your patience. That's a lot of content. But yeah, I'm not in a rush to go anywhere. If you guys have any questions, and yeah, please feel free to shoot away. No problem. So I've got a question around risk factors to diverticular disease. And yeah, it's essentially kind of a low fiber diet. It means that you're much more likely to have poorer transit and kind of a increased risk of constipation, which means you increase the amount of pressure, intraluminal pressure in the actual colon itself, which it can cause when you have a natural defect or a natural weakness in the wall. It can mean that can pop out, which is what a kind of a diverticulum is. So that's kind of a low fiber diet, and then smoking again can cause weaknesses, increased weakness and poorer healing, and then there's obesity and non-modifiable risk factors are largely genetic. Thanks so much for your time. It's a real privilege to be able to teach you guys.